All right, here we are for another one of our Learning Health System podcasts. Parsa, welcome. Good to see you as always.
See you too.
We're going to talk about NLP today.
Natural language processing.
Natural language processing. Thank you very much.
Clinical text understanding.
Yeah. Yes, even better. I think my first question is, why is it so important? When I talk to you about NLP, I feel like after search, sort of the query tool you built, I feel like NLP is the next thing you talk about. Why is it so important?
It is so important for several reasons. First of all, we naturally have a very good and intuitive understanding of narratives. We're storytellers, and we tell the story of the patients in a very broad and deep way in the clinical notes that we take. We document our interactions with the patients. Therefore, and the information that we read are clearly understandable for us. Whereas no one really is born with intuitive understanding of data sets to be queried. So it's a very intuitive content to understand, and we create copious amount of them in healthcare. So access to this rich and intuitively understandable information is critical for our ability to not only take care of patients, but also do research.
So I hate to break it to you, Parsa, but you're not the first one to work with NLP in healthcare.
Yeah, don't break my heart. Yes.
There are so many initiatives around natural language processing. What makes you think that what you've done is so important? What's so different? What's so special? What's so awesome?
I don't think that we have really solved an unsolved problem by building what we have built, which is what we call elastics. But we found that from a learning health system perspective, you need certain features and functionalities in your natural language understanding platform that existing tools are not built for. What we have done was to look into natural language processing as a process that needs to be fully integrated with the learning health system platforms. First of all, it has to scale, and it has to deal with all of the varieties of notes generated inside the health system. A big proportion of them are clinical notes. You can imagine every aspect of healthcare creates some different kind of note, and that variation needed better indexing, better cataloging, better structuring in a way that it can integrate to the rest of your analytics. And then there are all kinds of other notes generated as part of the operational process of care, right? The patient's complaints, patient safety reports, you name it, all of the operational perspectives, meeting summaries, meeting notes, anything that needs to be cataloged and connected. We needed a better, more scalable way of processing, cataloging, indexing notes in ways that we could understand them holistically everywhere, no matter who created them, how they were created, and so forth. We needed to do this in real time. So retrospectively looking into stuff of yesterday were not enough. We needed to bring them in and process them in almost real time.
So it's really the integration that is the novel thing here. What technology?
Workflow that would allow us to use clinical notes as an integral part of any analytics, not just standalone capability of some tool that for some use cases you can go to, but bringing notes and integrate that to your overall analytic platform for every use case.
So I have a two-part question. Part one is, if integration is so important, tell me a little bit more about those integration points. And part two is, did you leverage a particular technology stack, or did you develop some of this stuff de novo?
The answer is yes. Let's start with the second question first.
Okay.
We use a lot of open source, and our value-added contribution was in getting the architecture right in terms of how it integrates and interoperates with the rest of the ecosystem. Yes, our technology stack starts with Elasticsearch, which is a massive, super parallelizable text and document indexing framework. You get a lot of functionality out of the gate with Elasticsearch, and we built our UIMA framework on top of Elasticsearch to be able to basically make it scalable and more interoperable for NLP tools. So we can bring all of the open NLP infrastructure that we had available to us and scale from there. And then we, on top of UIMA, we added CTAKes, which is again a great work that the rest of the community has done on adopting clinical text understanding and ontology encoding frameworks in conjunction with the rest of the UIMA and open NLP infrastructure. And on top of that, we integrated that with our large language model ensemble, open source ensemble of large language models that we have fine-tune and continuously evolve to apply in a privacy-preserving way to our clinical text understanding problems. And that's probably another episode for itself. But now you have a stack of interoperable technologies that are not purpose-built. They're context-independent. They can be used for anything and everything. It's scalable. It's portable. We have versions of this running in Azure, as well as AWS, as well as in-house in our own cloud here. So we know it works. And to make that context-independent natural language processing architecture even more interoperable, we created a query language that essentially traverses between Elasticsearch query language as well as structured data that is generated by CTAKes and UIMA. So you can, if you're familiar with the CAS and analytic engines that UIMA generates, we can query CAS as well as all of the nodes as they are indexed by Elasticsearch using one query language.
So that was a great deep dive into the technology stack. How about the integration points, which was...
Yeah, so now that you have this infrastructure, what we have done is to, let's call it a demonstration project, right? Because as I mentioned, natural language processing has many applications in many places. It's not just one use case. We have created an environment where Elastics can be integrated directly to the workflow of cohort-based studies, using EHR-based studies for clinical research when you have to create a cohort, massage the cohorts to very specific inclusion and exclusion criteria that further characterizes that cohort based on combination of characteristics from structured data in EHR or patterns that you can find in clinical notes. Through that workflow, our users can combine these two query languages, SQL to OMAP, as well as Elastic Query Language to all of the nodes, to characterize patients, for example, as an example, patients that have a diagnosis of myeloma or are being treated for myeloma, but had history of military deployment to any of wars in the Middle East, or documented history of exposure to sarin gas or ricin and other chemical hazards or bioweapons. So these information are partly found when we talk about myeloma and your therapeutic history. they're best documented in structured EHR components. Part of your myeloma history may be captured in your pathology notes. A lot of your military history and your experiences like deployment here or exposure to certain hazards are captured in clinical notes or other history-taking experiences that you might have across the health system, almost everywhere, right? And that's just one query that we run, partly to OMAP, partly to Elastics, to find all of those patients and create a cohort out of them. So that's example one, fully integrated workflow for cohort-based study using Elastics. Demonstration number two is clinical trial matching. A lot of time, especially in oncology, your pathological history, either tumor staging information, your tumor size information, and its progression or regression over time is documented in many different places, partly in pathology, partly in your oncology visits. Your therapeutic protocols are fully characterized, and their coincidence with the tumor staging can be found in multiple places, but someone needs to read them and align them temporally and say, okay, at the time that you had this tumor stage, or your tumor size was this, or the metastases were in these locations, you were receiving these therapeutic protocols. Therefore, you are or you are not a match to a clinical trial. Very complex text understanding, clinical text understanding workflow, augmented and enabled by large language models.
Our previous episode is about TESA, which is clinical trial matching. And what I think I hear you saying is that TESA would not be possible were it not for Elastics.
If it was not integrated to a really robust clinical text understanding and natural language processing.
Right.
TESA is a standalone tool. I can give you like tons of other examples. You want artificial intelligence at scale in a healthcare system. These days, almost every deep learning algorithm or decent AI algorithm that I know is multimodal and needs to be able to look into embeddings and vectors in notes as well as structured data in EHR. And you do not want to create one NLP algorithm for this AI and one NLP infrastructure for that large language model issue. It just cannot happen in a learning health system. So we have essentially created one centralized natural language understanding clinical notes facility for learning health system. That is it your large language model ensemble? Is it your clinical trial matching? Is it your cohort-based studies? Is it your chart reviews for sepsis? Is it reporting and regulatory? It does not matter. They can leverage this very robust query in analysis infrastructure we've created, interoperability infrastructure we've created, to access and ask their questions and integrate with it. And I'm sure that we will do more as we learn more about it.
One of the things that has happened in the last 4 or 5 years are large language models. And large language models do an incredible job of going in and understanding text as it is deployed. Is the progression of these large language models going to make this kind of NLP technology obsolete? Or is it going to replace it? Or how does they two interact?
I don't think they will make them obsolete, right? Of course, they're super powerful tool, but they're also, I'm going to call them expensive computationally, and they take time. They're not as efficient in terms of scale. Well, you can make them efficient if you have a cluster of 2,000 GPUs. which none of us hospital systems do. So the question then becomes, what is the best use? How much of the problem you ask your big guns to solve, and how much of the these problems we can solve with smaller guns, less expensive guns. And finding that sweet spot is something that we are still working on. I don't have a recipe for it now, but I can
And my
tell
guess is it'll change over time as well.
yeah, when it's like genetics, right?
Yeah.
There was a time that one single genetic test was $1 million. Only a few of us could do it, and only experimentally, not just as routine. But now it is in hundreds, and almost everyone knows how to do one, and affordable, scalable. But we're not there yet. Large language models have many applications everywhere in natural language understanding and integrating analytics that requires really deep analysis of nodes. And we are halfway there in terms of understanding the applications and the efficiencies in terms of the cost benefit of adopting these large language models as an integral part of every analytic that we run. But they're also very expensive, both computationally and otherwise. The kind of workforce you need and the kinds of platforms you need, and security and privacy aspects of those things. What we have done is to basically architecturally build the interfaces. We've adopted open source extensively to address a lot of privacy and confidentiality problems that large language models and use of them may impose on us. And we have demonstration cases to show how we can use large language models at scale for natural language processing, for both creating rich and complete data sets, longitudinally integrated data sets for other analytics, or using language models as the analytic itself, for example, for chart reviews, for sepsis detection, and for clinical trial matching. So I'm sure that they're going to become more and more part of our analytic infrastructure as their costs of ownership reduces. But right now, we have use for all technologies that we have built in the past, and we are adopting anew as these generative AI algorithms and different language models are becoming more and more available to us.
Are there any risks of any privacy risks, compliance risk? I know there are, of including notes into the system.
Yes, a lot of them actually, because we document almost every conversation we have with patients, and those conversations a lot of time includes very personal information about the patients themselves, about their family history, and all of the other experiences that they might have during their delivery of care process. Clinical notes are considered protected by HIPAA, and you cannot really use them as is for research or sharing them with anyone without robust de-identification. And that de-identification should really take care of many information like the identifiers, locations, names of other people than the patient, care providers, family members, everything, addresses, phone numbers, email addresses. So a very complex set of information might be found at every corner of clinical notes that needs to be redacted. And then on top of that, every time that some of these documents like your psychology or psychotherapy note or information that may capture some of the experiences that you may have had, like family violence or family issues, they should be also logged, tracked, and audited if this information has been viewed by anyone other than the care providers that have access to this information. So not only information needs to be redacted and de-identified, if someone for any reason had the right to look into these information, and they did, those occasions where people have looked into this information should be logged and captured and should be auditable to just protect patients in an event that someone access their private information in unauthorized fashion. So these two aspects are at play every time that we're talking about NLP or use of nodes for analytics or research.
And my last question, how does all of this integrate? I know you're trying to build a learning health system at Montefiore. How does this all integrate into that larger ecosystem?
Architecturally, that was the question, right, that we asked. So there are so many NLP tools out there. What do we need and how do we need it in order to integrate clinical notes as an integral part of all of our analytics? Every time that people need information to do research, to take care of patients, to do quality improvement or what have you, in the context of learning health system, that continuous cycle of learning and research, we wanted to incorporate clinical notes and all of the notes in them. So architecturally, Elastics is designed to solve that problem by its multimodality to allow aggregation and indexing and integration of all modalities of notes in a queryable fashion where different modalities of analytics can be integrated at scale. I spoke about UIMA, I spoke about CTEX, I spoke about large language models. These are demonstrations of how we have been able to bring all of the technologies that we know have applications and we are going to learn about in the future to plug into this infrastructure in a way that we do not need to rip and replace every time that someone invents something new or there's a new interesting technology that we want to adopt, and creating these interoperability framework, the query language and APIs, RESTful APIs that people can connect and use that query language to interact with Elastics as if it is integrated to their platform. And it allows sharing this massive indexed and quality controlled and privacy preserving infrastructure, right? The secured and confidential representation of clinical notes with every analytics across the system, which is bread and butter of really large scale analytics in the context of learning health system.
Well, look, what's been amazing to me is, as someone who's seen Search and used it, you use Search and Elastics just as one thing. And so I'm delighted that we've had a chance to talk about the importance of NLP. Any last thoughts before we wrap up this episode of Learning Health System podcast?
No, this was great. Thank you. I appreciate it. And I think now that we have